I speak about this first part on highlights. Every one of you probably knows what the highlights are, but just for your information, during the Congress a lot of details are presented, and then at the end of the meeting we have the so-called highlight session, where for the different topics there's one person who summarizes the new evidence, the new data in a specific field, in my case imaging, that are then summarized. And that is what we share here with you. So I put there, thank you Dr. Delgado, because she was the one who summarized the things at the ESC meeting. And I've taken from those slides some slides that I'd like to share with you. What was presented is a lot, but what I thought was interesting for you is additional evidence on coronary disease. And the more we learn about coronary disease, the more we understand the issue of ischemia, stenosis, intervention, good outcome. But where we have trouble is the patient that present with an unstable syndrome out of the blue. The patient that all of a sudden has an infarction, or the patient that, even worse, experiences sudden cardiac death. We simply don't know yet what underlies this pathophysiology. So that is important. There is also more and more interested in aortic pathology, aortic dissection, aortic dilatation, aortic aneurysms. There was a focus on characterization of Lv mechanics. Mechanics are the advanced way of looking of Lv function. We used to look at left ventricular ejection fraction. Nowadays, we do understand that it's probably better to look at the performance of the muscle, the performance of the heart. And that is probably the best measure how your left ventricle is doing. And then the last thing is probably the most breakthrough in the field of cardiology is fibrosis imaging. We start to understand that a lot of diseases of the heart probably start with very little detailed fibrosis formation. If you have long-standing hypertension, the ventricle gets thicker and thicker, and what happens in the ventricle is that fibrosis is being formed. If there becomes more fibrosis, then the ventricle becomes stiffer, and that is then starting diastolic dysfunction. If it continues for longer, pure scar is being formed, and then the systolic function is going down. That happens with hypertension. That happens with valvular disease. If you have a severe aortic stenosis, there is a pressure overload of the ventricle. And each time when the heart is working, also more pressure on that ventricle, and fibrosis is being formed. If we could detect that earlier, we could intervene earlier. We could earlier take out the valve. There's a lot of things we could do actually. So these are the good things that we could work on if we would have a possibility to assess fibrosis. Further evidence on coronary disease, that's the first part I'm going to speak about. This is a registry where I was involved myself. This comes from a database set up by a guy called Jim Min in the United States who works at the Cornell University. And Jim Min has actually collected 60,000 CT angiograms, CT scans. And these 60,000 CT scans, we looked at the ones to determine the prognostic significance of atherosclerotic plaque characteristics beyond stenosis severity for identification of individuals who will experience future ACS. So what did we do? Out of the 60,000, we looked at the patient that had a CT scan within a time frame of a year more or less, and then later on developed an ACS or an infarction. There must have been something in that coronary artery that resulted in this infarction, and that is what we're looking for. And we match those with patients that have the same characteristics but did not get an infarction, and we see where the coronary arteries are different. And that's the first step in the direction of understanding who gets an infarction. So the atherosclerotic plaque characteristics that we looked at are the simple ones: stenosis, plaque burden, plaque composition. lipid dense core, low attenuation, that is non-calcified plaques. And arterial remodeling, that is dilatation beyond the stenosis. And here you see on the right in the panel, you see these different things. So you see here a heavy non-calcified plaque. If I show that here, you see that here. And here's the remodeling taking place. So these are the issues that we're looking for. We matched the population for the simple things: age, gender, CAD risk factors, angiographic coronary disease, more than 50% stenosis. And out of that we came with 234 patients that developed an ACS. And we have 234 controls. And when we look at their differences between an ACS and no ACS, we see that in the ACS there's more high-risk plaque. And high-risk plaque is all this information that I just gave you. Low attenuation means non-calcified plaque. The positive remodeling was more present. And little spots of calcium in the lesions are also indicating that this is an area where there's instability. The things that were not really important, there was some influence of the stenosis, but you see that the one that came out very strong in the multivariate is the high-risk plaque being present. So this is one step in the direction of better understanding what is a vulnerable lesion. We knew that. We have already seen before that the non-calcified lesions tell us something. The problem is that there are also a lot of non-calcified lesions who never get anything. So we go slowly in the direction that if you do your CT scan and you see a patient with an absolutely non-calcified plaque, you need to think something is going on. These results from this iconic study suggest a prognostic utility for characterization and quantification of coronary APCs for improved diagnosis of patients who will benefit versus not benefit from probable treatment and to prevent in the future ACS. We're absolutely not there yet. But the non-calcified plaques, and I already stated it in 2000, I think, means something. That is something that you need to keep in mind. Aortic pathology. Here is also the focus on inflammation and instability. What you see here is basically PET-CT, and you see the fusion of PET scan, which is the activity which you see here, the activity in the walls, and abdominal aneurysm growth occurs in steps. It's not gradually, but you have something, and then something occurs, and then again stable, and then again growth. It's currently impossible to predict on an individual patient basis the risk of rapid expansion or rupture based on only the diameter. So this PET tracer that there is available now, this is an 18-fluoride sodium tracer. It binds to hydroxyapatite, which is a key component of vascular calcification. And we hypothesize that the 18-fluoride PET-CT may predict aneurysm expansion and clinical outcomes. And so what they did in the study is they had a control group with small aortas, and then they had an observational cohort with dilated aortas. So they do a CT scan, then they do the sodium PET-CT scan, and based on that they fuse. And then you see areas of activity. And then they compare, or they combine the ones with high activity and look at ultrasounds every 6 months what's going to happen. And this is what you see here. The aortic events were rupture, further growth, or the need for surgery. And you see that the ones that show very high activity on the PET scan, they are the ones that get the events. So it's not so much the size, but it's more the biological activity. How much inflammation is there in this aorta? And that's what we learned from that. Now, if we speak about Lv mechanics, that is actually what we do with strain imaging. Most of you have seen this now over the last years. This is the deformation of the myocardium. It's no longer ejection fraction. It's the deformation or the strain of this myocardium. And the authors looked at increased mechanical dispersion. What does that mean? You have a ventricle, and normally all the parts of the ventricle contract at the same time together. But if there is some that contract early and others contract late, then you get a sort of desynchronous pattern. So this study looked on this dispersion, how important it is. Increased mechanical dispersion has proven to predict ventricular arrhythmic events. So it's an unstable substrate. It has a high risk of sudden death or ventricular arrhythmias. What they did is to investigate if this increased mechanical dispersion is present in individuals with lots of risk factors in the population of middle age. And this is what they found in 2,500 subjects with measurable dispersion. The median value was 38 milliseconds. And the patients that had more than that, they had a higher risk, or higher prevalence, I should say, of cardiovascular risk factors. They were more obese, had more hypertension, had more diabetes, had more renal failure, and more coronary artery disease. So more higher risk presentation. So this is actually telling us, if we see that in the ventricle, that we need to be aware that this patient is at risk of probably ventricular arrhythmias. This is certainly not so that if you see it, that the patient will get it. It's again the same with the non-calcified lesions. We start to understand which substrate relates to a certain outcome, but we cannot go the other way around, that we say if you have that, you're going to get that. So high sensitivity, low specificity probably, if you want to measure it like that. This is the last part, the fibrosis imaging. So what these authors did is they looked at the fibrosis imaging in aortic stenosis, and I already give it a little bit to you. If you have a high severe aortic stenosis, your ventricle needs to work hard to get the blood out. So what's going to happen? The ventricle is getting thicker and thicker, and eventually in the middle of that ventricle, fibrosis is going to form. And the more fibrosis there is, the worse the outcome is. That is what we anticipate. To demonstrate if parameters of left ventricular adaptation are predictors of mortality after valve intervention in aortic stenosis. So what does that mean? That means that we're going to look at parameters of left ventricular adaptation. That means dilatation, remodeling, but also fibrosis formation. And to see which one predicts, although you replace the valve, that the outcome is not going to be good. In other words, we're going to learn from this when we are too late. We do the valve, we do the surgery, but the outcome is bad. Could we have learned that from the beginning? So the study design is observational study, 6 centers in the United Kingdom between 2003 and 2015. 700 patients, that's quite a lot, with severe aortic stenosis. You see the severity of aortic stenosis, a valve area less than 1, the peak gradient more than 60, the mean gradient more than 40, and the velocity more than 4. And what they saw is that this fibrosis, which you see here, this white and the white here, actually that is very prevalent. They saw it in 50% of the patients. 34 had a non-infarct pattern, such as this. This is not an infarction. This means that there has been too long high pressure on that ventricle, and he's been pumping to get the blood out through the stenotic valve, and he had to work hard. So the muscle got thicker and thicker, and eventually what's going to happen is that the fibrosis is going to come. This is a patient with an infarct. So when there was no fibrosis, the outcome was as such. When there was more fibrosis, the outcome was much worse. Again, none of the phenomena that I show you today is 100% sensitive and specific. I think you should look at them as potential high-risk markers. And what we are doing is that we're making steps. We need to first understand the disease. Why does something happen? And if we do understand, we can go in the direction of therapy. But all of the things that I showed you today is first better understanding. They looked if the patients had a TAVR, a transcatheter valve, or a surgical valve, and whatever they looked at, each time when there was more fibrosis in the red curves, the outcome was worse. So you did replace the valve, but still at some time the outcome was worse. And the type of scar that was predictive is actually not so important. It's both the infarct scar and it's the fibrosis scar. The The take-home message for you is that if damage in the ventricle is occurring, either by an infarction or by long-standing pressure overload, that ventricle is not going to function that well anymore. So the take-home message is that if you don't have an infarction, but you have an aortic stenosis, you probably need to start thinking about earlier valve replacement and not wait too long. I hope I clarified some of the issues for you. Coronary CTA, CT scans with assessment of atherosclerotic plaque characteristics. The non-calcified plaque provides important diagnostic and prognostic value. There is a promising role of this sodium fluoride in PET-CT in the evaluation of patients with an aortic aneurysm. The more of this inflammation there is, the higher the likelihood that something is going to happen to him. The mechanical dispersion means something. You see it often, 50%, we saw it, in the presence of cardiovascular risk factors. That certainly does not say that all the patients need an ICD, absolutely not. But it's on the long road to better understand what happens in the heart. Myocardial fibrosis with the CMR, in this case with contrast, in aortic stenosis has prognostic value. We learn from this that probably things like aortic aneurysm repair, aortic stenosis replacement, we need to be earlier in the process than we're doing now. But we don't have the right tools to tell us exactly when to do operate or surgery or transcatheter valves. But we see that we each time are a little bit too late in these patients. So we need to think about better characterizing them. This is what I had to say. Thank you very much.